Good morning, everyone. Thank you so much for joining us for Grand Rounds. I have the honor of introducing our Grand Rounds speaker this morning, Dr. Natalie Hecht Baldauff. Dr. Baldauff is an assistant professor of pediatrics in the Division of Endocrinology, Diabetes, and Metabolism. She completed her medical training in the United States Air Force and served as a general pediatrician prior to her completion of her endocrinology fellowship at UPMC Children's Hospital of Pittsburgh. Following completion of her fellowship, she has joined the faculty here. Dr. Baldauff is an associate program director of the Pediatric Endocrinology Fellowship Program and the director of metabolic bone disease clinic. Dr. Baldauff is passionate about medical education and enjoys teaching medical students, residents, and fellows. It is our great honor to be able to have her here for our Grand Rounds. Thank you.
Thank you. Thank you so much for the introduction. So good morning, everyone. So today I'm going to be talking about osteoporosis in children, diagnosis, management, and future directions. So fractures are common in children. 50% of children have at least one fracture prior to adulthood. The most frequent site for fractures is the forearm, which accounts for about 50% of all fractures. And 65% of long bone fractures involve the upper extremity, whereas about 7 to 28% involve the lower extremity. So lifetime fracture risk for kids between birth and 16 years is high. Males, about 42 to 64% will have at least one fracture with a peak age of 14 years, and females about 27 to 40% with a peak age of 11. So, we definitely see tons of kids with fractures, and it can be difficult to know which kids we should worry about. So what contributes to fractures in healthy kids? So the metastases of long bones are thin, and cortical porosity is high. So this results in some transient cortical weakness of the bone. There's also about an 8-month delay between peak growth velocity and peak bone mass accrual, which also leads to that increased fracture risk in that window of about 11 in girls and 14 in boys. We also see a lot more children participating in youth sports. Finally, GWAS studies have identified genetic variants that can increase fracture risk by 10% or less. And I think this is overall a very minor contributor to increased fracture risk. And by comparison, if you consider kids with osteogenesis imperfecta, those kids have about 11 times or an 1100% increased risk of fractures compared to the general population. So those minor genetic variants do contribute somewhat, but the contribution is very small. So bone growth in kids occurs through bone deposition and resorption, which allows bones to expand and lengthen. This bone modeling begins during fetal life and continues through epiphyseal fusion in the later teen years. One of the essential parts of bone accretion is mechanical loading. So physical activity in kids is so important. And this is one of the reasons why our patients with neuromuscular disorders or patients with decreased mobility do have some increased risk for low bone mineral density. In children and young adults, that cortical density and structural strength continue to increase into the third decade. So I think the important point there is that children who do have chronic disease that contribute to issues even into young adulthood can go on to affect their bone health and strength into their adult years. So about 39% of the total bone mineral content is acquired during the 4 years surrounding the peak bone accretion. And by 4 years following the peak, about 95% of adult bone mass has been achieved. So this is one of the reasons why it's so important for us to consider pediatric bone health in our patients to ensure that we are doing everything we can to prevent low bone mineral density in at-risk patients. So the figure on the left shows that delay or that lag period of low bone mineral density. So for girls, your peak bone mineral accretion rate occurs at about 12.5 years and in 14 years in bone. But the peak growth rate is about 8 to 12 months younger. So in that lag period, so until 11 and a half to 12 and a half in girls and 13 and a half to 14 and a half in boys is where that increased fracture risk occurs. So osteoporosis, which was once considered a disease of the aging population, is now increasingly recognized in children with genetic disorders causing bone fragility and in children with chronic illness. It's characterized by low bone mineral density and impaired microarchitecture, which can lead to decreased strength and fractures. So defining osteoporosis has been really a pretty controversial topic over the years. So I'd like to walk you through a timeline that explains some of these evolving definitions, and it can help to establish sort of a basis for where our criteria for diagnosis come from today. So in the 1990s, there was widespread availability of bone mineral density assessment by DEXA. And at that time, the adult strategy was adapted to kids, and the diagnosis of osteoporosis was made based on a BMDZ score, which was less than or equal to minus two standard deviations. So after the 1990s, there was an outcry of publications which stated that there was an underestimation of BMDZ scores due to short stature and pubertal delay. And there were also concerns about lack of natural history studies in kids and using that absolute cutoff of minus 2 standard deviations. In 2007, the International Society for Clinical Densitometry convened a task force which recommended that the definition of osteoporosis in kids be reserved for children with a clinically significant fracture history and a BMDZ score less than or equal to minus 2. So after this, multiple studies showed that BMDZ scores varied considerably based on the normative database, which called into question the use of the BMDZ score in kids. The most up-to-date position statement was published in 2013, and this is where our criteria come from today. So the updated pediatric position statement stated that the diagnosis of osteoporosis in children should not be based on bone density criteria alone. It highlighted that non-traumatic vertebral compression fracture is an indication of osteoporosis without the need for a BMDZ score less than or equal to 2. If you don't have vertebral compression fractures, you should make the diagnosis of osteoporosis by the presence of a clinically significant fracture history and BMDZ score which is less than or equal to 2. So they define a clinically significant fracture history as greater than or equal to 2 long bone fractures by 10 or greater than or equal to 3 long bone fractures by 19. The paper appropriately states that BMDZ scores greater than or equal to minus 2 does not preclude the possibility of skeletal fracture and increased fracture risk. And this last point was supported by the Canadian STOP Consortium. So this was a prospective multi-center study. STOP stands for Steroid-Associated Osteoporosis in the Pediatric Population. And they looked at one of the groups of patients that they looked at in this study was children with ALL, who often have high risk of vertebral fractures due to steroid treatment during chemotherapy. And what they found in the study was that children with ALL and vertebral fractures often had BMDZ scores that were above minus 2. Although the study does note that there was some variability there depending on the normative database used to generate those Z scores. So the most up-to-date, recently in 2019, the ISCD published an update which discussed that proximal femur can be used as a DEXA site in children with reduced weight bearing or in those who are at risk for bone fragility who may need screening into adulthood. You can also measure the 1/3 radius in children who cannot be scanned at other sites, or the lateral distal femur, which can correlate with lower extremity fragility fracture risk in non-ambulatory children. So I think the overall take-home points from these different position statements and something that's consistent across those position statements is that DEXA is the preferred method for assessing bone mineral content and aerial bone mineral density in kids. The preferred sites are the posterior anterior spine and total body less head, with a minimum interval between scans of 6 to 12 months. So there are some challenges to diagnosis of osteoporosis in children. So one of them is that defining low energy trauma has been a major obstacle to diagnosis. The 2013 ISCD criteria may lead to underdiagnosis with that cutoff of greater than 2 fractures by 10 and greater than 3 fractures by 19. So the question that has been asked is that should clinicians wait for a second or third fracture when the first was life-altering? So consider the patient, for example, with Duchenne muscular dystrophy who has a significant femur fracture. Those are patients that probably should be referred earlier than their second or third fracture. The BMDZ scores have also been a challenge to diagnosis as they can vary depending on the reference database used to generate the Z-score. And finally, children with bone fragility due to disorders such as leukemia, chronic kidney disease, neuromuscular disorders, and OI can sustain fractures when their BMDZ scores are greater than 2. So there are some members of the pediatric bone health community who've recommended a more contemporary approach for diagnosis of osteoporosis. by first assessing patients' risk for fractures, then assessing their fracture characteristics, so the location, mechanism of injury, and unusual features. Asking whether the patient has a history of low trauma vertebral fractures, if they have any findings which suggest an underlying disorder of bone fragility, and finally, whether they have a family history of bone fragility, as many of our patients with osteogenesis imperfecta have a family history given the typical autosomal dominant inheritance of that disorder. So worrisome findings in patients. So the first being any low trauma long bone fracture. And I think it's very important to remember that a single low trauma long bone fracture may be a major osteoporotic event in children with an initial presentation of OI and in patients with Duchenne muscular dystrophy. So those patients should, again, be referred early. If patients have comminuted fractures or atypical displacement in the absence of trauma, that's highly concerning for a bone fragility disorder, as are flat bone fractures, the scapula, sternum, skull, and rib. Pseudofractures are these looser zones. These are incomplete cracks at the cortex of ribs, scapula, medial shafts of long bones, and pubic rami. And these can occur in some other disorders, including hyperparathyroidism, renal osteodystrophy, OI, fibrous dysplasia, and also hypophosphatasia. If patients have any radiographic findings of rickets, that does take you down a different diagnostic pathway, which we'll discuss in a few minutes. And fractures in non-ambulatory kids, delays in care, unexplained bruising, fractures in various stages of healing, or an unclear mechanism of injury should all be things that are concerning for child abuse. So what is a low trauma fracture? So this has been a very challenging thing to define. So the 2013 ISCD criteria were not very helpful. They recommended excluding all fractures from motor vehicle accidents and falls from 10 feet or greater. I think we can all agree that that's significant trauma, and there's probably, or most definitely, significant trauma that is less severe than that definition. So that's where defining that mild or moderate trauma becomes much less clear. Leanne Ward's group uses a conservative definition in children with chronic illness, and I think this is a great definition to use for patients, especially our patients with known bone fragility or with chronic disease. And their definition states that a fracture sustained falling from standing height or less at no more than walking speed should be considered a low trauma fracture. So when we're evaluating a child with clinically significant fractures, the first step is to rule out a disorder of bone mineral metabolism. It's important to remember that pathologic fractures are typically seen only in severe cases of rickets. So the patient that has vitamin D deficiency without clinical findings of rickets, the pathologic fracture is unlikely to be secondary to the vitamin D deficiency alone. When I'm assessing these patients, I always ask about dietary intake and supplement use. Initial labs should include calcium, phosphorus, magnesium, PTH, creatinine, alkaline phosphatase, 25 and 125 vitamin D, and then urine studies for calcium, phosphorus, and creatinine. So vitamin D intake. Your vitamin D is going to be present primarily in your milk and milk alternatives such as soy milk, coconut milk, almond milk, and rice. It's important to remember that the Department of Agriculture does not require that producers of milk fortify with vitamin D, though FDA says that you can put up to 205 IU in 8 ounces of milk. So I typically ask what patients are drinking and try to determine whether or not that's a source of vitamin D or insufficient vitamin D for them. Similarly, yogurts and cheeses are not always fortified, whereas other foods such as cereals, juices, sometimes less healthy foods, Pop-Tarts, and other pastries are often fortified with vitamin D. So for recommended amount of vitamin D for kids, 400 IU is recommended in children from birth to 12 months, 600 IU in children who are 1 to 18 years. So these higher, though I will say, 600 IU is the recommendation, but what we find is that higher doses are often needed in those with obesity, malabsorption, and darker skin. So recommended calcium intake for age between 1 and 3 years is 700 milligrams, 4 and 8 is 1,000 milligrams, and 9 to 18 is 1,300 milligrams. So to give you a sense of how you would get to that recommended daily intake, a glass of milk is about 270 milligrams, 8 ounces of low-fat yogurt is 415 milligrams, and 1.5 ounces of mozzarella cheese is 333 milligrams. So kids do have to have fairly significant dairy intake to get that calcium purely from diet alone. So what is rickets? So rickets is an abnormality of growing bone characterized by a growth plate defect and impaired skeletal mineralization. In rickets, you get this hypertrophy and disorganization of the chondrocytes and the cartilaginous epiphyseal plate. And rickets generally can be divided into two major groups, calcipenic and phosphopenic. But I think it's important to remember that regardless of the etiology, low serum phosphate is the basis of the growth plate defect in rickets. So if you divide rickets into calcipenic rickets and hypophosphatemic rickets, certainly this is a lecture all in and of itself, but I think just for the purposes of this talk, remembering that calcipenic rickets is related to a defect in quantity or effective vitamin D, you end up with decreased serum calcium, increased PTH, and ultimately that lower exposure of the growth plate to serum phosphorus. So these disorders would be vitamin D deficiency, any disorders of vitamin D metabolism, and then nutritional calcium deficiency. Hypophosphatemic rickets can generally be defined as disorders of increased FGF23, with the prototypical disorder being X-linked hypophosphatemic rickets, and renal defects, which can include hypophosphatemic rickets with hypercalciuria and Fanconi syndrome. So clinical features of rickets, if you see these features, this makes it much more likely that you're seeing rickets versus a hereditary disorder of bone fragility. So skeletal deformities depend on the age of the patient. So infants get this craniotabes, or this kind of depressible, or sometimes called like a ping pong skull. You can also see frontal bossing, widening of the wrists, and visible enlargement or palpable swelling of that costochondral junction, which we sometimes refer to as that rachitic rosary, which you see along here. Toddlers and older kids will have the effect of weight bearing on their physical features. So in crawling kids, you'll often see bowing of the long bones of the arms versus bowing of the lower extremities in children who are walking. So step 2 in evaluating a child with clinically significant fractures is determining if the child has an underlying systemic disorder, which may be associated with secondary osteoporosis. So the most common disorders are neuromuscular disorders, glucocorticoid-treated Duchenne muscular dystrophy, other glucocorticoid-treated disorders such as rheumatic diseases, inflammatory bowel disease, myasthenia gravis, and leukemia. So there are multiple causes of secondary osteoporosis, and each one of these could probably be a lecture in and of itself, but a couple important things to point out. Many of our hospitalized patients fall into many of these chronic illness categories. And many of these disorders, as I've highlighted glucocorticoids under medications, are glucocorticoid treated conditions. And so there is some overlap in the effect of the chronic illness and the effect of medications. Similarly, in the endocrine disorder category, we don't often see pathologic fractures in many of the endocrine conditions, even though these conditions do predispose patients to osteopenia and osteoporosis. Neuromuscular disorders are probably the largest source of patients in my bone health clinic. Patients with Duchenne muscular dystrophy have kind of a double hit where they have not only long-term glucocorticoid treatment, but they also have that neuromuscular disorder, which does contribute to bone strength and actually overall bone mass. So the next step is to obtain appropriate imaging in a child. So there are 3 imaging studies that should be considered. The first is lateral thoracolumbar spine radiographs, and that's to assess for those evidence of vertebral compression fractures. The second is bone densitometry. And so one of the things I would suggest is, if you're considering ordering a bone densitometry for a patient, if you are concerned about pubertal delay or there's clinical concern for delayed puberty, please obtain a bone age, as our radiologist can interpret the DEXA based off of the skeletal age or developmental age of the patient, as well as the chronologic age. Understanding that, for example, a male who is 14 years of age, who's still Tanner stage 1 for pubertal development, is going to have a lower bone mineral density than a 14-year-old who's already completed linear growth. And then if you have concerns that for other abnormal features in the patient, a skeletal survey can be very helpful. This can assess for things like Wormian bones and other skeletal deformities, which may point you in the direction of an inherited disorder of bone fragility. So a little more detail regarding vertebral fractures. So the definition of vertebral fractures is a 20% loss of vertebral height ratio using this Ganant semi-quantitative method. So the Vertebral height ratios are generated for anterior fractures when the anterior height is compared to the posterior height, and that creates this anterior wedge fracture. And this is the column on the far left here, where you can see as fractures worsen, you can see that wedging that happens with the vertebrae. For what they call biconcave fractures, you're comparing the middle height of the vertebrae to the posterior height. And for posterior wedge fractures, you're comparing the posterior height to the adjacent posterior site, and you can see that in the far right. So symptoms of back pain, lower extremity bone mineral density Z-scores, and steroid exposures are predictors of Gannett-defined vertebral fractures. So vertebral fractures are frequent manifestations of osteoporosis in high-risk conditions such as osteogenesis imperfecta and glucocorticoid-treated illnesses. So if you see these patients, you should have a very high index of suspicion for vertebral fractures. They've been shown to occur in about 25% of children with motor disabilities, and are frequently asymptomatic and can go undetected in the absence of trauma. So it can be very hard to tease out, especially if you have a child who is non-ambulatory and is nonverbal. So this is a situation where thoracolumbar spine radiographs can be very helpful to delineate whether there's a problem. The thoracic region is the most common site in children and adults for those vertebral fractures. So first line for detecting vertebral fractures is conventional radiography due to ease, availability, and low cost. And that's figure A on the right. And you can see, especially in the thoracic region, some of that anterior wedging that is consistent with those vertebral fractures. However, multiple studies have evaluated sensitivity and specificity of DEXA-based vertebral fracture assessment. And the most recent update from the International Society of Clinical Densitometry states that DEXA vertebral fracture assessment can be used in place of spine radiography. So you still would use that Gannett semi-quantitative method to define fracture. It is important whenever, if you are using vertebral fracture assessment via DEXA, that an experienced evaluator is reviewing those studies. It has the benefit of lower radiation exposure, though the upper thoracic area, which is usually your most common site for fracture, is a little bit more difficult to assess in those patients. So what's the role of DEXA in bone mineral density assessment in kids? So DEXA is a reproducible, inexpensive procedure, and radiation exposure is low. Lumbar spine, L1 through 4, and total body less head are the preferred sites in children. And as I mentioned earlier, the guidelines also endorse DEXA-based bone mineral density on the distal forearm, proximal hip, and lateral distal femur in special cases. So you get a raw numeric value, which is converted to age and sex-specific Z-scores. Height Z-score adjusted BMD should be done in children with permanent or temporary short stature to avoid underestimation of bone mineral density. So I think probably the most important point when considering DEXA is it's not diagnostic for osteoporosis, and it should be viewed as a piece of the puzzle and a guide to pursue comprehensive workup and a guide to determine treatment or how effective your treatment is, rather than a diagnostic study. It can be low in non-osteoporotic conditions. So rickets is a prototypical disease that is associated with lower bone mineral density, and which is not a true osteoporotic condition. And BMD can be normal in kids with fractures due to primary and secondary osteoporosis. So what are we doing here at Children's Hospital of Pittsburgh? So we we do bone densitometry using the GE Lunar DEXA. So a couple of just important points for those of you that are ordering DEXAs on your patients. So when ordering, we ask that patients hold calcium supplements prior to their DEXA study, as undissolved calcium tablets may introduce small artifacts on L1 through L4. There's a couple of adult studies published on this. The literature is not overwhelming, but I think it's not harmful to do that in order to get the best and most appropriate imaging. If skeletal delay is expected, please order a bone age and add a comment to the order if adjusted DEXA result is needed. That way the radiologists know to read the DEXA based off of the chronologic age and the skeletal age. So in our institution, for patients without skeletal delay, we're reporting total body less head and lumbar spine in kids up to 15 years of age, and then adding the spine and the hip when patients are 16 years of or age of older. And we're doing this to ensure that as kids transition to adulthood, where the hip is used as a skeletal site for bone mineral density, that there is some comparison study that helps with that transition into adulthood. So if patients do have skeletal or pubertal delay, we will do total body less head and spine up to 15 years of age, and then total body less head, spine, and hip when 16 years or older. An important point to remember is that there are no standardized Z-scores for children under 5. So this doesn't mean that you can't order a DEXA in a child under 5, but it does mean that we want you to consider carefully whether or not that DEXA is a needed piece of that puzzle. There are some smaller studies with some reasonable data looking at Z-scores and of the lumbar spine in kids under 5. But I think for these kids, I think DEXA should be reserved for a baseline prior to treatment rather than sort of part of your diagnostic workup. So I wanted to review for a few minutes glucocorticoids in bone, because I think this is a really important part of pediatric bone health that spans multiple specialties. And it's certainly one of the main reasons why we see kids in our clinic for skeletal fragility, which is unrelated to inherited disorders of bone fragility. So endocrinologists, we have a love-hate relationship with glucocorticoids, and I have a little bit more of a hate relationship when it comes to bone, because these kids really can struggle with bone health, especially with long-term treatment. So glucocorticoids, they increase apoptosis and decrease growth plate chondrocyte activity. They also increase osteoclastic bone resorption. They have effect on intestinal calcium absorption and renal calcium reabsorption. They're decreasing osteoblast bone formation, and they also decrease that osteocyte mechanosensors. So even kids that are ambulatory and that are trying to have that mechanical loading, the glucocorticoids interfere with that, and that can contribute to poor bone health on steroids. So I mentioned earlier the steroid-associated osteoporosis in the pediatric population trial. And so this was a 6-year multi-center observational cohort study in glucocorticoid-treated children. And some of the data that came out of this trial was very helpful. So vertebral fractures are the hallmark of pediatric glucocorticoid-induced osteoporosis. And most importantly, they can occur early in the treatment course with a peak incidence at 1 year, but we have seen it as early as 4 to 6 months following glucocorticoid initiation in kids with rheumatic disease or Duchenne muscular dystrophy. They can often be asymptomatic when severe, though I will say we also see many patients who have very severe back pain related to their vertebral fractures. So it's not always an asymptomatic fracture. So moderate to severe vertebral fractures are the strongest independent predictors of incident vertebral fracture, more so than bone mineral density. So especially in our patients on glucocorticoids, we have to have a very high index of suspicion for vertebral fracture. And even mild vertebral fractures are independent predictors of future vertebral fracture. So in patients who are on glucocorticoids, bone health monitoring should begin at the time of glucocorticoid initiation in high-risk populations where long-term treatment is anticipated. And so, and then children where they're expected to receive greater than or equal to 3 months of daily oral or intermittent IV therapy at supraphysiologic doses, monitoring should begin as soon as possible. So physiologic doses of steroids is about 8 to 10 milligrams per meter squared per day of hydrocortisone equivalent. So it really doesn't take much to have supraphysiologic dosing of steroids. So just as an example, for like a 45 kilogram patient, a prednisone dose of more than 5 milligrams would be considered supraphysiologic. And many of our patients are on much higher doses of steroids than that. So recommended monitoring for patients on glucocorticoids includes lateral spine imaging at baseline and annually. You may want to look at those lateral spine imaging sooner if there is a greater than 0.5 decline in bone mineral density on consecutive measurements. And these patients should also have bone mineral density by DEXA at baseline and annually. So can children recover without bisphosphonate therapy who have glucocorticoid-induced osteoporosis? And the answer is yes, though though you have to look at whether kids have a greater or less potential to do so. So kids that have less potential for recovery without medical therapy include those who are on greater than or equal to 3 months of steroids, have subnormal mobility, who have poorly controlled underlying disease, are older and therefore closer to skeletal maturity, and who have more severe vertebral collapse. The kids who have greater potential to recover are those on less than 3 months of steroids, who have short-term immobilization, who have well-controlled underlying disease, who are younger, and who have milder vertebral collapse. So the population that tends to fall into this greater potential category is our kids with ALL, because they're on short-term steroids and they actually remodel quite remarkably after they finish their treatment, often without bisphosphonate therapy. So I'd like to move into primary osteoporosis. So primary osteoporosis can generally be divided into type 1 collagenopathies related to disorders of COL1A1 and COL1A2, which accounts for about 85 to 90% of cases of osteogenesis imperfecta. The other 10 to 15% of causes of OI include mutations in genes involved in bone formation, differentiation, and mineralization. And then there's this kind of sort of rare and sort of puzzling diagnosis of idiopathic juvenile osteoporosis, which we will review. So OI is the majority of cases, as I mentioned, are due to mutations in COL1A1 and 1A2. There's a very broad severity spectrum, which ranges from early onset osteoporosis to progressively deforming and lethal, perinatal lethal OI. So in the type 1 collagen, which is pictured on the right, you have 2 of the collagen 1 alpha 1 chains, and you have 1 of the collagen 1 alpha 2. So the type 1 collagen is your major component of your bone extracellular matrix and your major determinant of bone strength. So in these alpha chains and alpha 1 chains and alpha 2 chains, you have typically a repeated sequence of glycine XY with the proline and hydroxyproline typically at positions X and Y. So the pathogenic variants that alter the structure of type 1 collagen that result in more severe clinical phenotypes are ones where there's a glycine mutation. The variants that are typically more nonsense or frame shift mutations that lead to haploinsufficiency generally result in milder cases of osteogenesis imperfecta. There are now, multiple other genes that have been identified, and this has really been some of the most exciting news in the pediatric bone health community in recent years, as there have been now multiple genes that have been discovered and implicated in pediatric bone fragility disorders. So there's a number of autosomal recessive variants in collagen synthesis, post-translational modification, intracellular trafficking, and cross-linking that lead often to a moderate to severe OI phenotype. The first 2 genes listed, this CRTAP and LEPRE1, are both associated with perinatal lethal forms of OI. There are also a number of genes that are not linked to type 1 collagen. This IFITM5 is an autosomal dominant mutation, typically causes OI type 5, as well as a number of other non-type 1 collagen genes. These genes encompass the now more than 19 types of OI that have been identified in the medical literature. We won't review all 19 types, but I think important for us as clinicians to know about the most common types of OI. So type 1 OI is caused by mutations in COL1A1, and it's an autosomal dominant mutation. And these kids have usually mild, it's usually a mild phenotype, and they have normal to short stature with little to no bone deformities. These kids often have blue sclera with conductive deafness, usually developing a little bit later in childhood or early adulthood. Type 2 OI can be caused by your COL1A1 and 1A2 autosomal dominant mutations and other autosomal dominant rare forms, as mentioned on the previous slide. So these are kids that have probably the most severe form of OI with death at birth or shortly thereafter. They can have minimal mineralization of the calvarium, beaded ribs, underdeveloped lungs, and long bone deformities. Type 3 OI is your autosomal dominant, also autosomal dominant mutation. And these kids probably have the most severe clinical phenotype, have severe short stature, progressive deformities, also have a triangular face and gray blue sclera. And then your OI type 4, again, also autosomal dominant. And these are patients who have OI of moderate severity with short stature. So clinical manifestations of OI, of course, will include low trauma fractures and fractures in atypical locations. Vertebral fractures can occur in 70% of patients with OI, so screening these patients at diagnosis and annually for vertebral fractures is very important. Severe forms will have in utero fractures and shortening of the long bones detected on prenatal ultrasound. Moderate to severe forms have bowing of long bones, scoliosis, and rib deformities. Short stature can be seen in both mild and moderate to severe forms. Another kind of rare finding in some of the more severe forms of OI, typically most commonly described in type 3, is this craniocervical junction abnormality called basilar impression. And this refers to an abnormal position of the odontoid process of C2, where the tip protrudes through the foramen magnum, and you can see this in the photo on the left of the skull base. So this often requires surgical decompression. And what you can see in here, this is an MRI, which actually shows the M here shows an indentation of the medulla in this example of a patient who had basilar impression. So this can be a surgical emergency, and I guess it does require surgical decompression. So other clinical manifestations in these patients include joint hypermobility, gray or blue sclera, dentogenesis imperfecta, which is pictured. These kids can have discoloration of their teeth, missing permanent teeth, and pretty severe malocclusion. Hearing loss in patients with OI typically occurs in the second or third decade and results in conductive, sensorineural, or mixed hearing loss. And we see this most commonly in our patients with type 1 OI. Cardiovascular abnormalities can be seen, including aortic root dilation, valvular dysfunction, and rarely aortic aneurysm and dissection. There's been increasing literature regarding pulmonary manifestations of OI in recent years. You do see, as would be expected, sometimes rib fractures, scoliosis, and muscle weakness all contributing to decreased pulmonary function. Pulmonary function does decrease with age and is most significantly compromised in type 3, which is your more severe type of OI. But intrinsic lung disease has also been described. The paper published in Clinical Genetics in 2018 described that patients with OI type 3 can actually have significantly reduced FVC and FEV1. So idiopathic juvenile osteoporosis. So this is a term applied to primary osteoporosis of unknown etiology in previously well children. It's a rare self-limiting disorder with an incidence of about 1 in 100,000. So the typical patient is an otherwise healthy patient that presents between 8 and 14 years of age, with the typical onset occurring about 2 to 3 years prior to puberty. And they can present with long bone fractures, back pain, and difficulty walking. There are also, interestingly, some dental abnormalities that are described, which also always makes me wonder whether or not there is, we will at some point not have an idiopathic juvenile osteoporosis, but rather a genetic, underlying genetic etiology at some point in the future. So it's the idiopathic juvenile osteoporosis molecularly is characterized by decreased bone formation in trabecular bone and the absence of increased resorption or cortical damage. So if there's a question as to what's going on with your patient, one option, though invasive, is transiliac biopsy, which can differentiate it from OI, which actually will show decreased cancellous bone volume, increased turnover, and thin cortices. So for these patients, spontaneous remission usually occurs around the time of puberty. Presence of vertebral compression fractures is an indication to treat these patients with bisphosphonates. So drug therapy and osteoporosis. So nitrogen-containing bisphosphonates are the mainstay of therapy, though none are FDA approved. So these are, so bisphosphonate therapy in kids is strictly compassionate use, even though we do treat quite a few kids. So bisphosphonates are synthetic analogs of pyrophosphate, which inhibit your osteoclast activity and induce osteoclast apoptosis. So the most common bisphosphonates used are permethrinate and zoledronic acid, or Zometa. And this study published in 2019 after an observational cohort study to look at effects of bisphosphonate exposure in kids with OI, it showed that IV bisphosphonates are superior to oral bisphosphonates in children. So for the large majority of our patients, we are treating with either IV permethrinate or IV Zometa. So prior to beginning bisphosphonate infusions, most important things is to rule out any potential underlying disorder of calcium or vitamin D metabolism. The ideal vitamin D prior to therapy is 50, though I have personally found that this can be difficult to achieve in some patients. Monitoring after infusion includes a serum calcium at 24 to 48 hours. The nadir for calcium levels or hypocalcemia after can be between 1 and 3 days. So often for my bisphosphonate naive patients, I may check at 24 and 48 hours, again at 72 if they're still low. After about a year of bisphosphonate therapy, if I know that patients have done well without post-infusion hypocalcemia, I do discontinue those post-infusion checks. So most common side effects are fever, nausea, vomiting, and body aches. So really these flu-like symptoms. And they're typically worse after the first infusion and oftentimes don't recur with subsequent infusions. They're treated with conservatively with fluids, Tylenol, and ibuprofen. Hypocalcemia is, of course, a side effect of bisphosphonates, and it occurs due to the osteoclastic inhibition of bone resorption. Some patients do require supplemental calcium and activated vitamin D pre and post infusion. Typically, I will, if the patients are on calcium, I'll have them double their oral calcium for a week before and a week after their infusion. For patients that have severe hypocalcemia, I will often add calcitriol before and after as well. Hypophosphatemia can be seen, and I've seen some impressively low phosphate levels after bisphosphonates into the 1 range, though supplementation is generally not needed or recommended. So rare side effects of bisphosphonates. So iritis is reported in anecdotal case reports, but is certainly a very rare side effect. Any child with a red or painful eye following bisphosphonates should undergo an examination by ophthalmology. Atypical femoral fractures are described, and this is often a question that patients will get because this is something that people see online. Is my child going to have this atypical femur fracture? And in the review of the literature, we don't really know if these atypical femoral fractures are drug related or if they're disease related, understanding that patients with OI certainly can have atypical femur fractures. But regardless, it's not an indication for treatment cessation. Probably the most common question I'm asked about bisphosphonates is whether children are going to get osteonecrosis of the jaw. And I think that the important point for everyone to remember is that there are 0 published case reports of this occurring in childhood, but definitely for our patients with OI, we recommend routine dental care. Pregnancy should be avoided for about 12 months after bisphosphonate therapy. So bisphosphonate therapy should be withheld until there's evidence of callus formation at a site of a fracture or osteotomy. And this becomes really challenging, especially for some of our younger OI patients who are just starting therapy, who are fracturing all the time. So this sometimes results in a delay in their bisphosphonate infusions. And this recommendation came from a case control study showing delayed osteotomy healing in children with OI following IV pamidronate therapy. So typically, if they do have a fracture, especially if they've had surgery or they've just seen orthopedic surgery, I typically wait for their first follow-up with ortho to confirm callus formation before I proceed with their next infusion. So absolute contraindications to therapy include pregnancy, renal impairment due to renal clearance of bisphosphonates, active rickets, and any sclerotic lesions or hypophosphatasia. So at our institution for patients with OI, I use the Omaha low-dose protocol. This comes out of Children's Hospital of Omaha. Initial infusions for bisphosphonates are split between 2 days for the first infusion, with the dose increasing based on age. For our older patients and subsequent infusions with OI under 2, we treat with 0.75 milligrams per kilogram every 2 months, between 2 and 3, 1.1 milligrams per kilo every 3 months, and greater than or equal to 3, 1.5 milligrams per kilogram every 4 months, with a maximum single dose of 60 milligrams. So what about secondary osteoporosis? So there's insufficient data to recommend pharmacotherapy for prevention of osteoporotic fractures in children. And this is always a challenging thing for me personally, because I definitely see patients that I know have terrible bones, right? And how do we make a decision what to do for those patients? So we're not recommending therapy at this point, but obviously close monitoring is key. For children that have had low trauma fractures who've limited potential for spontaneous recovery, those are patients with secondary osteoporosis that should absolutely be treated. So duration of therapy often depends on the underlying condition. So transient conditions, so things that were, for example, those patients that are on steroid for a moderate amount of time, We recommend discontinuing therapy if patients demonstrate reshaping of their vertebral fractures, absence of any new fractures or any new non-vertebral fractures, and gains in BMI Z-score. For our patients with long-term risk factors or inherited disorders of bone fragility, the recommendation is actually to treat until final adult height is reached. And the reason for this is that fractures have been shown to occur during drug holidays. So kids improve, bisphosphonates are either halted or discontinued. The new bone, the newly formed bone during drug holidays is of lower density and can actually place patients at risk for new osteoporotic fractures. You definitely can reduce the dose after 2 to 3 years, especially if you're seeing gains in bone mineral density. And this reduces the risk of oversuppression of bone turnover and excessive gains in bone mineral density. So I wanted to highlight a couple of other treatments that are in the medical literature but are not yet being used regularly in children. So denosumab or Prolia is very well known to the adult population, but we use it obviously much less in kids. So this is a novel human monoclonal antibody, and it targets rank ligand. So rank ligand is a cytokine that mediates osteoplastogenesis and osteoblast survival. So, so it works really the same, the ultimate outcome is very similar to bisphosphonate therapy. This is a great, it's a great drug in terms of convenience for the families, as it's a subcutaneous injection every 6 months versus IV pamidronate, which is every 2 to 4 months, or Zometa, which is every 6 months. There's a shorter half-life of about 30 days in contrast to bisphosphonates, which remain in the bone for years. So pediatric trials with denosumab, it's been trialed in OI type 4 in patients who responded poorly to bisphosphonate therapy, and the effect on bone mineral density was variable. A multi-center trial currently is ongoing, looking at denosumab in the lumbar spine bone mineral density at 12 months in children between 2 and 17 with OI. Another drug is teriparatide. This is a parathyroid hormone analog, and it's the first anabolic therapy approved for use in adults with OI. This drug is not used in kids, as preclinical studies in rats that received high doses raised concern for osteosarcoma. There was an exciting trial for the DMD community published just in December of 2020. They looked at 6 DMD patients who were on long-term glucocorticoids who had severe osteoporosis despite bisphosphonate therapy. And those 6 patients actually had favorable results. So longer trials are obviously needed in order to determine if that's a promising therapy for those patients. And then a couple of drugs on the horizon. Again, this is, you're going to see this more in the adult literature. Sclerostin inhibitory antibodies. Evenity was recently approved for adults with osteoporosis, and this targets sclerostin, which is a glycoprotein that inhibits bone formation via Wnt signaling in osteoblasts. And a trial is ongoing for adults with OI types 1, 3, and 4. And finally, anti-TGF-beta antibodies. So it's been shown that continuous activation of TGF-beta signaling leads to low bone mass and bone fragility in OI. And a clinical trial is also ongoing with OI and moderate to severe OI. So in summary, most important points regarding pediatric osteoporosis. So remember that the criteria for diagnosis of osteoporosis in children includes low trauma vertebral fractures alone or low bone mineral density for age combined with multiple low trauma long bone fractures. It is never wrong to refer a patient who has that first concerning fracture. We are happy to see those patients and work them up and see if they warrant medical therapy. Please have a high index of suspicion for vertebral fractures, including, especially in our glucocorticoid treated population. They can be asymptomatic and they can occur in children with normal bone mineral density. The positive thing and the great thing about kids is kids do reshape and they restore bone density spontaneously, though this is more common in younger children with mild disease and transient risk factors. So again, please refer those patients who are higher risk or lower chance for recovery. And pharmacotherapy is indicated for children with primary osteoporosis and those who are unlikely to have spontaneous recovery. Thanks.
Thank you so much for that wonderful presentation. I think we already have a couple questions that have flooded into our Q&A. So first is excellent presentation. For a follow-up, DEXA scans is the recommendation still to make the scan, make sure the scan is done in the same machine between different scans?
Yeah, that's a great question, actually. So I do encourage my patients, or I more than encourage, I ask them to please have their DEXAs done at the same location because of that variability in reporting of Z-scores. So if they start having their DEXA scans done here, then we continue that moving forward.
Great. And then another question is there a role in growth hormone as an adjunct to bisphosphonate, especially in children with OI or muscular dystrophy?
Yeah, so I can definitely answer that question. In the muscular dystrophy population, the literature does not support growth hormone treatment in those patients. So our DMD patients, again, often have significant short stature, and they, of course, have related to their glucocorticoids, but growth hormone does not improve their growth, nor does it significantly improve their bone mineral density.
Thank you. And then we just had one sort of comment about differentiating between child abuse from other pathologic fractures as well.
Right. Yeah. So I think this is I think that's a challenging thing to do, certainly. And I probably most importantly, involving child advocacy if there's concerns, and doing due diligence in the workup. So many of these patients we do have to do genetic testing for if it's unclear, and making sure that that a thorough workup is done, ruling out all other causes, especially for those unclear cases.
A comment or a question from Dr. Germany is fantastic talk. And would you say a few words about the mechanisms of the autosomal dominant mutations in OI and how do they work?
So the autosomal dominant mutations in OI really the effect is on type 1 collagen. So you have any of those mutations, typically what happens is you have a mutation in glycine usually, and that results in an abnormal type 1 collagen molecule, which ultimately affects bone strength, because type 1 collagen is sort of your main determinant of bone strength. So it's those mutations that affect either folding or packaging, or the way that type 1 collagen is formed in the bone.
From Dr. March, says fantastic presentation. Can you speak to the effect of height Z-score on DEXA interpretation in addition to skeletal delay?
Yeah, so you can, so there are height Z-score adjusted reporting for bone densitometry. So there is some software that does this, and there are actually some great, CHOP actually has a great calculator online that you can do this. So if the patient has significant short stature, using a height adjusted Z-score is recommended, because a very short child is going to have essentially falsely low bone mineral density. So there are some algorithms and some software that you can use to do those calculations.
Fantastic. And one other question from Dr. Pahalik. She said, thank you for a great talk. In regards to glucocorticoid-related osteoporosis, what duration is considered long-term, and is there a timing threshold effect? And does the risk increase linearly with the duration of therapy? And can the risk be reduced with alternate day dosing?
Those are all great questions. So long-term is actually considered greater than or equal to 3 months. So in many of our patients, that doesn't seem like a long time, but understanding that the first vertebral fractures can occur 4 months after a therapy, anyone that's on or expected to be on greater than 3 months would be considered long-term glucocorticoids. Is the effect linear? I don't know the answer to that question. I think that obviously longer exposure is going to create multiple issues with the bones. So I'm not sure if it's a linear, but I think you're definitely going to have compounded risk over time. Remind me of her last part of that question.
The last question was just, can the risk be reduced with alternate day dosing?
Yeah, and that's actually being looked at in our DMD population. So there is a current ongoing study looking at dosing DMD patients on the weekend, and I know that our great group of people in our DMD clinic here are doing this in some patients, and I can tell you that, like, anecdotally, without telling you that trial data, the DMD patients that I take care of that are on weekend dosing of deflazacort or of prednisone, definitely they grow better. They have less risk of hypogonadism, which definitely plays a role. So these long-term glucocorticoid treated patients also have significant pubertal delay, which then compounds their risk for bone health concerns because of lack of sex steroids. So the patients who are on weekend dosing definitely do better in my personal experience, and that study is currently ongoing to look at that.
Very interesting. We got another question. So thank you for an excellent talk from Dr. Escolar. What is the recommendation for patients who are not ambulatory, especially children with CP that develop severe osteopenia due to not weight bearing and are at risk for fractures?
Yeah, so those patients should definitely be screened, and there are some guidelines for using bisphosphonates in those patients. And so typically with those patients, the way I approach the non-ambulatory patients with like CP is, I screen them for vitamin D deficiency, make sure that they're receiving sufficient calcium in their feedings. Many of these kids are obviously at high risk, and when you do a bone densitometry on them, they have low bone mineral density. I would certainly have a low threshold for treatment, especially after a first osteoporotic fracture in those kids, and not waiting for fracture 2 or 3 before initiating treatment. And that's a challenging population because sometimes imaging in those kids can be very challenging because of lateral spine. Films can be challenging. Many of these kids have had hardware in their spine or hardware in their legs. So it does make obtaining bone density measurements really, really challenging. And that's where I think that on the horizon is we should be considering some of those alternate sites for bone density measurement in those kids, and potentially using that as a guideline. So if a child's had a fracture and we're seeing declining bone mineral density in that population, having a higher, a greater drive to treat them with bisphosphonates for sure.
Great. Well, thank you so much. I think those are all the questions that we have in our Q&A. So I ask everyone to join us for our meet and greet. The link is in the chat, and we look forward to seeing you there. Thank you so much.